Then we have cranial nerve number 2. With cranial nerve number 2, you want to look at visual acuity in pupils, visual fields, and you also want to use your ophthalmoscope to look at the retina. One thing as doctors that you will carry around, or hopefully you will carry around in your pocket, will be a little card, which is called a Snellen card, all right, that will allow you to take somebody's visual acuity. And what you normally do is you have the person hold it in their hand. Now, on the bottom of all of these cards, there's the same little paragraph here that says, card should be held in good light 14 inches from the eye. And so do I get my ruler out and make sure that the person is exactly holding it 14 inches away from their eye? No, I don't do that, okay? Instead, I do a much more practical thing, which is I ask a very important question. What's the question? Do you wear glasses? Exactly. All right. So I remember when I was a student, I forgot to ask that question. We were going through this, and they were doing terrible, and I spent 5 minutes on it, and then they asked at the very end, you want me to do this with my glasses on? Oh! So you just wasted 5 minutes. All right. So again, you want to ask them at the head of time, you know, do you wear glasses or contact lenses? Put them in, because we're going to check your visual acuity. Now, the way it works here is you have them, you cover one eye, and you have them read the lowest line here. And that little line is 428739. Can you all see that? Oh, no, I just had that memorized. So if they get that right, I have them cover the other eye and see if they could read the same line. But I have them read it backwards, because if they just read 428739 and they have that in their mind, they could be blind as a bat in the other eye, and they remembered 428739, so they're going to get it right. So I kind of trip them up a little bit. And when I cover the next eye, I say, okay, right, read that same line, but read it backwards. Okay, so that's how I do it. Now, they are allowed to get one thing wrong per line, all right? And if they get one thing wrong, you can read here on the side here what their visual acuity is. If they get 2 things wrong, then they got to go to the next line. They get 2 things wrong on that line, they got to go to the next line, okay? And when you look out here on the side, these are the visual acuities. So, for example, you know, what if somebody is 20/20 in their right eye and they're 20/50 in their left eye? What does that mean? Okay. Well, if you're 20/50, what that means that what a normal person can see at 50 feet, you have to go up to 20 feet in order to see it. Okay, that's what that means. Okay. You also need to know ophthalmological abbreviations. So OU, 20/20 OU, means that both eyes are 20/20. Now, if you have different visual acuities for the 2 eyes, you need to be able to, must know the abbreviations for the 2 eyes. So when you're talking about the right eye, it's OD. And when you're talking about the left eye, it is OS. Okay? How are you going to remember that? Well, I think the person who dreamed this up was right-handed. And so OD, the right eye, the right hand, is your dexterous hand, OD, okay? And we all know that all left-handed people are sinister, so that's OS. Although left-handed people probably use more of their brains than right-handed people are. I think that whoever made this up was a righty and was jealous of the left-handed people. But anyway, the other thing that you'll see on the bottom here is a pupil gauge. So you'll be able to identify how large the pupil is. And again, that is not so incredibly important as you know, whether their pupils are both 2 millimeters or they're 9 millimeters. In that the pupil size will change depending upon the ambient light in the room or how nervous the person is. The more nervous the person is, are their pupils going to get smaller or larger? Larger, okay. So if they're in the emergency room and they're scared, their pupils are going to be huge, you know. And so I don't really care how large they are, but I care about one thing that is another common theme in the neuro exam, and that is what we're always looking for in the neuro exam is asymmetry, okay. So asymmetry implies pathology. It doesn't guarantee pathology, but it implies it, okay. It's more important, again, you know, there's certain drugs, of course, that can cause a person to have small pupils or large pupils. More important finding, and should catch your attention, is when pupils are unequal. Now, there's a word for that, too, that you need to know. Do you know what the word is? It's called anisocoria. Anisocoria. Okay, so when you talk to your attending, you know, you say, oh, this patient has anisocoria. You know, you have to use the proper terminology. You're doctors in training, so you got to learn all the lingo. Okay. Now, this is one of the ways to test visual acuity, and I think it's a stupid way, okay? Because again, here's the examiner, here's the person that's being examined, and that person's sticking their fingers out, and what are they going to ask that person? How many fingers do I have up? Okay, well, is it 3, or is it 2 and 1? And are we talking about your left side or my right side, or is it your right or my left? You know, oh, I don't do that, okay? Instead, I do this, which is called confrontation. I don't do it exactly like this. So, can I have a volunteer? Volunteer? Quick, quick. Come on up. You, yeah, come on up. Okay, so I want you to sit right here. All right. And I'm going to confront you. No. All right, so you are the examiner, all right, and you have to, you are the control, all right? So you look at my nose, I look at yours, okay? And I put my hands out here in the periphery, and I'm going to ask the patient, point to the hand, rather than say, you know, how many fingers do I have up? And then there's a confusion about left and right and all that stuff. I just say, point to the hand where the fingers are wiggling. Good. Okay, so that's how you do it. Okay. If a person, let's say, they see this and they see this, but you show them this and they focus on one, then you know something may be wrong. Okay. And so then what we usually do is we get a card or a piece of paper, and we check what are called the quadrants, because not only do you have is the visual fields cut in halves, but there also can be cut in quadrants, as you'll learn when you learn about the eye pathways, which you'll have a lecture on in the future. So in this way, if we have to look at the quadrants, I will cover one eye, and then I'll close my eye across from the one that I'm covering, and you look at my eye, I look at yours, okay? And tell me when you can see my thumb. Okay? Yeah? Okay? Good. Okay, so then of course I'm going to do the other side. All right, well, thank you very much. Give her a hand. You can do it a number of different ways. This is checking for the quadrants, and he has a little probe out there that he's using. But I think you could just use your thumb just as well. But again, it's done to confrontation. And again, anatomical pathways have to make sense. One of the things that has to be occurring when a person has a field cut is that for you to know that most of the field cuts, in order to make anatomical sense, are what's called homonymous. Okay, so what does that word mean, homonymous? It means that you can take the field cut in the left eye and you can superimpose it onto the right eye. Okay, so if a person can't see in this quadrant, they should not be able to see in this quadrant. That's homonymous. All right. There's one exception to the rule, and that is when you lose your peripheral vision, all right? Now, your peripheral vision is your temporal vision, okay? So this is called a bitemporal hemi-half anopsia field cut. Bitemporal hemianopsia. And you will learn, when you learn the visual pathways, that this is a lesion that's in the optic chiasm, okay? So, what would you call this? And you want to be professional about it, what would you call it? Well, that is a left homonymous superior quadrant anopsia. So that's what that is, okay? And again, if you get one eye, which has a lesion up here, you think, and then the other eye has a lesion over here, that doesn't make anatomical sense, okay? So now, realize that what we did over here is a very gross exam. And so, as neurologists, we're kind of screening for ophthalmological problems, but really the experts are the ophthalmologists. So if I do find something that I think is iffy, I go get a consult and get my ophthalmology friends involved in the case, because they have a machine they could put the person in called a Goldman perimetry tester. And they could not only show me exactly how big the field cut is or where the field cut is, it could actually even show me where the blind spot is. Now realize that we have a blind spot in our eyes that we can't see. It's where the optic nerve is. And our eyes jiggling all the time so that you don't really notice it, but it's there. And this machine can actually pick it up, but I can't pick it up on the exam, Okay, so if I suspect that there's any kind of problems with visual acuity, or that's a serious one, or a field cut, or with pupils, or any of these other eye issues, I usually get ophthalmology involved, and they'll do a much more extensive exam. Now again, remember the anatomy of the third cranial nerve when we're looking at pupils. Light reflex comes in and will go to the midbrain and stimulate both Edinger-Westphal nuclei, which will cause both pupils to constrict. All right? Realize also that after the third nerve exits, you have your parasympathetic. Those parasympathetic fibers are on one surface and can be injured by an external mass. Many times it's an aneurysm, but it could be a tumor. And you can have anisocoria without a third motor lesion. Okay? In addition, you can have a third motor lesion without anisocoria. And we've talked about this already. And what disease likes to do that? Diabetes. And we actually call that the diabetic third. Or if you have a complete third, of course, you have everything gone. But again, to remember about this anatomy, that the parasympathetic fibers, again, are on one surface. The other thing that we often do as neurologists is we shine the light in one eye, both pupils should go down, and we shine the light in the other eye, both pupils should go down. But many times neurologists stress the system a little bit. They go and swing the flashlight from one eye to the other, one eye to the other, one eye to the other. And what you may find is that you get if there is an old lesion in one of the optic nerves, many times it's a demyelinating lesion, so related to multiple sclerosis many times, that you'll get what's called the Marcus gun pupil, where instead of, after you swing the flashlight a couple of times, when you go into the bad eye, so to speak, it would be a sluggish response, and instead of that pupil getting smaller, it will actually get big, all right? And you should not see that. So, but you can stress the system, and you can pick up a subtle lesion in the optic nerve by doing this little test called the swinging flashlight test, and not just check one pupil, check the other pupil, and be done. All right. So neurologists, again, usually do it a couple of times. Now, you can do that with a pen light, but you're going to also look in the retina. And so if you're going to be doing that, you might as well use your ophthalmoscope. So you all have to learn how to use an ophthalmoscope, okay? And I think that you're probably going to have to buy one, unfortunately, because there are going to be some instances where, like when you're in the emergency room, every room has an ophthalmoscope in it, but there are going to be some instances where, you know, you're not going to have an ophthalmoscope. There's not even going to be a wall. So you're going to have to, I think, just like you're going to have to buy yourself a stethoscope, you're going to have to buy yourself an ophthalmoscope. Again, this takes practice looking in someone's eye. You want the pupil to be as large as possible. And of course, you can do that by putting drops in their eye, but you're not going to do that because that's going to mess up their visual acuity. So what you do to make the pupil, the window, as large as possible is you do what? Shut the lights off. Okay, and the pupil will get large, okay? And then another thing I do is I shine a light in the most corner of the room, as far away from the patient as possible, and have them focus on that spot. Because focusing on a faraway object does what to the pupil? Again, makes it large, okay? So you want that window, that pupil, to be as large as possible so you can look through it and actually get a visualization of the retina. All right, and this is what you should see. Well, actually, that's not true. This is what an ophthalmologist would see when he uses his device to take a little snapshot and you see the entire retina. What you're going to see is you're looking for the optic disc, okay? And again, all the blood vessels are coming out of the optic disc. But when you're using your little handheld ophthalmoscope, you may only have a window about this big, all right? So you turn the dial around and you try to focus on something. Usually it will be one of these blood vessels, okay? So once you're focused on it, then you try and follow it back to the disc and go around the disc and then look at the center of the disc. And you have one goal, really, to do, is to rule out papilledema, which is this looking like it's coming out at you like a mound. A papilla is a mound, okay? This is what a normal retina looks like, and that's what papilledema looks like, okay? Now, I realize that this is a flat picture, but when you're actually looking at a real retina, you'll get the appreciation that not only is this angry looking, but also this mound is coming out at you, okay? And again, what does papilledema mean? Papilledema means that there's pressure. Where's the pressure? Well, it's behind the eye. Where? In the brain, okay? So that means something bad is happening in the brain in order to get papilledema, okay? This is what you're trying to look for, is papilledema. That's what you're trying to rule out. Now, you may see some other things, like, for example, if someone has had damage to their optic nerve, the optic nerve may atrophy and become white like this. That's called optic pallor. Okay, so if you see that, you know that this eye probably doesn't work. Also, this is a very important thing that you may, when you're looking around, you may come across one of these things. And if you pick it up, boy, this would be a great pickup. What is this again? A Hollenhorst plaque, again. This is a little bit of cholesterol that has flown from someplace and wound up in your eye, and it could wind up in your brain as well. So this is a stroke waiting to happen. This person is a stroke waiting to happen. And so if you can pick this up ahead of time, before the person has a stroke, you can perhaps prevent them from having a stroke, and that would be wonderful. Now, this is another thing, I don't know if you get an appreciation for it, because it's a two-dimensional picture, but in 3 dimensions, what this optic nerve head looks like is that looks like you're looking down in a funnel, okay? You're looking down into a funnel. So these blood vessels are going down into the hole there, okay? So that's a pressure problem too, but the pressure is not in the brain. Where's the pressure? In the eye itself, okay? And that's a disease called glaucoma, all right? So you may be looking for one thing and you find another. So again, the optic nerve head is again pushed away from you, like you're looking into a funnel. That means the pressure problem is in the eye itself, and that's glaucoma rather than papilledema. Again, look at most of these lesions are homonymous. Okay, and you're going to get this again in your eye lecture. But there's, again, one exception to the rule, the tunnel vision, where you lose your peripheral vision. So I would have gone to you, and I would have stuck my hands out, and I said, which hand is wiggling? And they'll say, I don't see your hands. Uh-oh. So then I'd have to move it in more and more and more until she finally saw them. Okay. So when you have this kind of tunnel vision, again, that means that the lesion is in the optic chiasm. What if the patient walks into your room and they look like this person? You know, you went, oh my goodness, there's something wrong here. All right? And there's actually a medical term for this. You can't say that this person is cross-eyed. No, you can't say that. You're doctors. So there's a word for this, and what's it called? It's called strabismus. You would say this person has strabismus. Okay? And when you see this, the person should have a complaint, shouldn't they? What should be their complaint? They have double vision, okay, which is called diplopia. What if the patient says, I don't see double, I see triple? Hello, psychiatry, I have a patient for you to see. You cannot see triple, all right? Unless you have a third eye hidden somewhere up there. You know, you're a mutant or something. You only have 2 eyes, so you can only see double, okay? And there are some people that do get hysterical. Now, let me also point out that a person can have strabismus like this and not see double, and then the person can have not very obvious strabismus and do see double, okay? So when you see somebody that comes into your office and they look like this, rather than trying to figure out, is this cranial nerve 3 or 6 or what is this? You should say to the patient, do you have any problems? Do you notice that your eyes are not aligned very well? Talk to the patient, okay? So when you see asymmetry, before you get excited and try and figure out where the lesion is, talk to your patient. I noticed that your eyes are not quite aligned. Oh yeah, when I was a kid, I had this lazy eye, and and I've always been like that. Or this happened a couple of years ago after I got in a car wreck. You know, and this is a prosthetic eye on this side. You know, you may see that sort of thing. Okay. So again, this is called strabismus, and the person should have the complaint of diplopia. Okay, if they do have strabismus and it's new, and your responsibility to diagnose what the problem is. So again, you have 3 cranial nerves that move your eyeball around: cranial nerve 3, 4, and 6. And we're going to show you a little bit about how to examine the person. Realize that here are all the muscles that pull the eye in certain directions. In primary position, of course, the person should not have strabismus. They should be looking straight at you, all right? And you can see what all the muscles do when they pull the eye one way or another. Most of these eye muscles are linked to cranial nerve number 3. Okay? And as a whole, if the cranial nerve number 3 is out, the person cannot move their eyeball medially. 6 is just opposite of 3, goes to lateral rectus, and as a result, the person can't move their eye laterally. Right? And then finally, cranial nerve number 4 goes to the superior oblique, and we'll talk about what that's all about in a second.